Good afternoon and good evening to everyone. Welcome to today's webinar, Expert Dialogue, all about COVID-19 from testing to clinical management, presented by Wondfo Biotech. First of all, thank you all for taking your time out and being here today. This is Janice from Wondfo Biotech, and I'll be moderating today's webinar. So we all know that it's already been a year and a half since the outbreak of COVID-19. And from the very beginning, we know nothing about this coronavirus, but a highly contagious respiratory disease, all thanks to the efforts of scientists around the world. And we have gained so much more knowledge about coronavirus so far. And especially with the popularization of vaccines, detection strategies has also evolved and changed accordingly. But the situation of this epidemic in different countries, they're not quite the same. And some countries had it under quite good control through a series of measurements like large-scale screening or quarantine or like cities lockdown. And these measurements did prove to be effectively prevent the spread of the virus. But however, for some countries, the situation are not that satisfying. And they're facing even more serious problems like medical system, like overwhelmed medical system and shortage of vaccines, even not to mention the diagnostic reagents. So therefore, we can see that a series of questions will arise, like how should we adjust our current diagnostic methods and how to conduct the most efficient strategies? And how do we monitor the physical condition of COVID-19 patients? So to address these questions, here we invited two experts from this field to share their insights on the testing strategy and clinical management of COVID-19 patients. And now please allow me to introduce our speakers. And the first one is Dr. Josef Scheiber from Germany. He is the founder and managing director of Biovariance, and he will talk about the testing strategy for COVID-19 in Germany. And Dr. Josef, you can say hi to our audience.
Hello everyone, and thanks a lot for the opportunity to be able to present some of our work in an overview of the general ongoings here in Germany.
Thank you, Dr. Scheiber. And the second one is Aamir Ijaz from Pakistan. He is the professor of chemical pathology in Muhyiddin Islamic Medical College, and he will talk about the biomarkers for monitoring of COVID-19 patients' clinical management. And Professor Aamir, you may say hi to our audience now.
Hello everyone. I can see a lot of participants, and thank you very much, Wondfo, Amber, and Janice for inviting us on this webinar. And from two different parts of the world, we are here together to how to tackle this menace. Thank you very much.
Thank you as well. So thank both of you for joining us today. Before we officially get started, just a few housekeeping notes. To ensure the best audio quality, please turn volume up. And at the end of the webinar, we'll have a Q&A session. So if you have any questions during the presentation, you can either submit your question to Q&A section or directly add them to the chat. And me and my colleague will sort these questions out and then deliver them to our experts. And if you miss anything, also don't be worried. A recorded version of this webinar will be uploaded then to YouTube Wondfo official account. So now let's get straight into the content. And Dr. Josef, you may go ahead.
You want me to share my slides now, correct?
Yes, you may share your screen now.
Just to make sure you're seeing the first slide now.
Yes. Oh,
okay.
We've already seen that.
Okay, thank you very much again for this opportunity to present about the strategy here in Germany and some of the very local specifics we had in the region where I'm sitting, where I will say a few more words about that. And yeah, I'm also looking forward to a discussion afterwards. But now let's dive into the agenda. So I will give brief background and intro from the localization and how the whole thing developed, how this testing strategy developed over the time, what the outcome was and is, and around specific timelines, and then further focus specifically also on antigen testing, on how this has been used here in Germany, is still being used, and also speak about the very interesting study we did with the rapid test from Wondfo based on our testing center here and the results and so on. So I will go through the slides now, but I'm also looking forward to a discussion afterwards, and I'm also available for questions whenever needed. So as this is a very international webinar, let me first show where we are located. So if we take a map of Europe and see Germany here, the easiest is to where I'm sitting, draw a line from Rome to Copenhagen, draw another line from Paris to Prague, and maybe another one from Amsterdam to Vienna, which are some of the more well-known cities here in Europe. And where these lines cross, this is where I'm sitting right now. If we move into the map of Germany, it's also kind of halfway between Munich and Berlin and Frankfurt and Prague, part of the Nuremberg metropolitan region, which is one of the economically strongest regions here in Germany. Basically, we are located here in the heart of Central Europe. So the geographical center of Europe is about 5 kilometers from here. And I will speak about some specific challenges we had and how the whole story with COVID developed. So how did it start? There was the local Bavarian Carnival holiday end of February 2020, so 1.5 years ago. And a very popular tourist destination at this time of the year is Ischgl in Austria, which is about 4 hours south from here, where quite a few people were traveling there. And there was one super spreader event because one barkeeper there in the most frequented bar was one of the first cases of COVID here in Austria or Germany. So from there, it quickly made from the tourists its way to the region where I'm sitting now, the Tirschenreuth district, one of Germany's 400 districts. And 1 week later, if you look at the date, this is a yearly beer festival that is very common, and also see many people dancing and having fun. So very easy for a virus to spread, and nobody knew already that the virus was there. Even they were advertising the event as fun, as oral vaccination against the virus, it says here in Germany, which turned out to not be very smart because it caused quite a few cases. So maybe I do it that way. Because 2 weeks later, the first lockdown for a town in Germany that it was announced was the town of Mitterteich, where exactly this happened. So, but initially, what diagnostic methods did we have and what do we have now? Of course, everyone knows about this antibody, antigen, and PCR testing. Initially, this was a very cold shock. We only had PCR testing available, but getting to a result from the swab took 10 days and longer. Quickly, sequencing-based methods we had available, but of course, this is also not that brilliant if you need to quickly distinguish between patients and non-infected people, because the general strategy is that the local health authorities are contacting and tracing all the contacts of infected people to put all those people under quarantine. So if one person is infected, all contact persons from the last 10 days will also be put under quarantine for 2 weeks. And so the region here was hit, the first one. We were really literally the first one in Germany to be hit. The first death cases that occurred from the COVID-19 happened here 10 kilometers from here. So we were exposed to that very early on, which then of course led to the fact that the virus and the spread of the virus was studied quite heavily and is still studied quite heavily with antibody tests to see how high the number of previously not discovered infections is. And particularly in young age people, it turned out that there were so many non-symptomatic cases, which explained the further spread. So a usual measure people use here is the incidence, meaning the cases for infected people in 7 days in 100,000 people population. So we had the highest incidence of that in Germany, and then only later in the year, but I will go into this a bit more detail, also rapid testing became available for professional users. Generally, of course, if we look into the drawbacks and strengths of each of the diagnostic methods, PCR is, of course, the gold standard because it can be implemented relatively quickly, but initially this was not in place, and we had very long turnaround times of around 10 days getting from a swab to diagnosis. Although we were able to sequence positive cases very early on, but this is not feasible for routine testing. The antibody blood testing became available quicker, but the big advantage of the rapid test with the immediately available results when people have symptoms only became available later in the year, which I will go into more detail in the further slides. So now we are in March 2020 and we have the first lockdown announced in Germany, and the testing situation and also the tracking from the health authorities is a very chaotic situation. So the whole, everyone had to adjust, and this is totally new. Nobody had experienced a pandemic before. So all this concept of not being allowed going outside and so on was totally new, and desperately looking for solutions for quicker testing and so on. So, of course, one specific point that needs to be mentioned is, beside the tracking infections by health authorities, that Germany is the most data privacy paranoid country on this planet. So the health authorities didn't even have the rights to access all data that was needed, which turned out to be also a problem, because in certain cases people were plainly lying about their contacts and so on. So this has developed better and has become better, but initially caused also very high numbers of infections, which was then also proven by when the first antibody tests became available a few months later, to show that there were many more people infected. Then in June last year, we were already quicker. The PCR results took around 4 days at the time. This is our health minister in Bavaria, Klaus Holecek. They announced a strategy that everyone living here in the state of Bavaria, and then it was expanded to Germany as well, can test whenever they want, how often they want, and it is being paid for by the state. To get a handle on the number of infections and really discover infections early on, and also a lot of testing become compulsory. So people working in elderly care or child care had to have to take 3 PCR tests a week and so on to really be able to identify cases early on, which then later in the year was also amended with the rapid testing when this became more broadly available. So if we now look more locally in starting with this implementation here in September, a major player is the Red Cross that set up, along with people from the army, different test centers. So basically every town with above 5,000 people or so got its own test center with a high throughput. There were still not that many labs available that could do the analysis, but so the swabs were driven daily around the state and the country, a couple 100 kilometers to go from the test station locally to the lab. But this was already quite good, because then the time from a swab to PCR was 1.5 days, and at the time the first professional rapid tests became available. So this was a bit amended, that everyone was basically tested every second day or so. And if there was a positive case, immediately a PCR was also taken, and the time the result was already a lot quicker. Still, the numbers were not developing that great, but then when the vaccination campaign started in late December last year, we also set up in this building here a concept where a testing station, a vaccination center, and a lab are co-located so that the swabs that are being taken can be immediately analyzed, and also in parallel the rapid tests are being run. So with this integrated concept where we got involved, we set up the lab, and now usually the time from a swab to PCR result, so if you have a positive rapid test, the PCR is taken, and also everyone is also taking, who is in certain professions, is taking at least one PCR test a week. And now we are down to 2.5 hours between swab and result, which definitely had a major impact. But at the time in February this year, the district here, Tirschenreuth, which is one of the 401 districts here in Germany, had the highest incidence, the highest number of per capita cases in Germany. But it developed very well. Once we had started producing quick results, now, just 3 weeks ago, we were also the first district in Germany that got down to COVID-0, and we are maintaining this number since then. So one other interesting part besides the quick tests, so if you look into the students at schools have to test 3 times a week. 2 times it is a rapid test, but also then a pooling tests with gargling water are performed. So all the students are just gargling plain water, which is collected and pooled in something like that, and then is analyzed by PCR. And only if there is a positive pool, it is further analyzed. And all these measures helped us really getting from the one hand being the one most extreme, having the highest incidence per capita, now to having the lowest a few months later with the measures taken. And now having this availability that if you do a quick test with the Red Cross, you get the result immediately, also in a digital format. And this is one of the things that has advantages, the officially performed test. So you can use the certificate to access gastronomy or certain places where you need proof that you are COVID negative or vaccinated. But this is the issue now. Also, self-tests are very broadly available and very, very affordable, but they are not very popular, unfortunately, although they would be a really great help in finding the further cases. Because there is no official certificate linked to them. If it's a rapid test being performed by one of the official stations, you have a certificate for 24 hours, which you don't have with a self-test. So a concept for that would be very helpful in the future. Also, a rapid test that performs better for non-symptomatic people, because the rapid tests are really brilliant if people already have beginning symptoms. If they would be also looking more into non-symptomatic people, this would be interesting. Of course, here our very German problem with the data privacy will have to be addressed further. If we look into the current application of the home antigen tests here in Germany, this was very interesting. We basically went from virtually no availability in January to abundant availability. You can now buy these tests everywhere at gas stations, every shop, everywhere you can buy them. Initially, a test was around 20 euros or even more than that for a common public. Now we are below 1 euro with the standard price. So a drugstore will usually sell these now at maybe 75 cents. But still, the real self-tests, although they are very beneficial to find cases, are not so popular due to the lack of a certificate. If this can happen in the future, this will of course have way more impact. And then further, this is the strategy that is being pursued here, to have 3 levels of testing in the future, going from a rapid test, and depending on the result of the rapid test, then do a PCR, and also later on monitor the antibodies. So now we are at the moment, the vaccination percentage in Germany is around 53%, but we will have to further understand how do the antibodies develop. So the technological quick testing for antibodies and so on will also be very relevant in the future. So, and this brings me to a point to mention one study we did with the actual test from Wondfo, where we compared it in more than 250 samples with various cases of positives and negatives with a PCR result. And really in the positive cases with low CT values, so with a significant virus load, the test really performed more or less perfectly. Only if the CT value got higher than 30 or 33, the occasional problem occurred with the test. But generally, the test really shows we were able to show to a standard, gold standard PCR. But if you have a well-performing rapid test, you can achieve very similar results at a way quicker time frame. And so if we can solve that issue with the certificate here in Germany, it would probably be no problem to have more or less everyone testing daily to have get a very good grasp on what is going on with the virus. We, of course, also did some other research with partners, which led to some publications already, particularly about SARS-CoV-2 infections in cancer patients. So very interesting point. On one thing we discovered that people under chemotherapy usually don't have symptoms if they are infected with the virus, which is probably related to the fact that the chemotherapy inhibits the DNA polymerase. And as there is no virus growing later on, these people also rarely have antibodies, even though they were infected before. So this is also some of the research we did in parallel to this pandemic thing. Maybe another word to the region and the company we are located. So we are in the top 10 highest growth regions in Germany now. Usually 25 years ago, this was directly at the Iron Curtain between the East and West bloc. But nowadays, we have a very central location, very high quality of life. Biovariance, the company, we usually don't do COVID, but we did it because it was necessary, and we had the local expertise. Usually we are active in personalized medicine, in oncology, and therefore also the oncology connection, and also neurological applications. So we get some recognition there. And basically the team at the time when we started were around, so we increased the team size by around 40% during the pandemic to be able to tackle all the different points. Okay, so this brings me to the end of this talk, but I can speak to every detail or give more details to every point you might be interested in. And just feel free to ask either here in the question in the session later on, or per email and so on later. Okay, thank you very much again for the opportunity here, and then I will stop sharing. This is fine, right?
Okay, thank you, Dr. Josef. Very interesting sharing. Yeah, so the local testing. Okay. So the local, yeah. Can you hear me? Okay. So the local testing strategy in Germany proves to be very effective, right? So now, right after a patient is diagnosed with COVID-19, and then the problems will immediately transfer to how to like monitor the physical condition of the patients and for the clinical management of the patients. So next, let's welcome Professor Aamir to share his insights on this topic. Professor Aamir, you may share your screen now.
Okay, thank you very much. First, thank you. First of all, I want to thank Wondfo and Janice and Amber for giving me this opportunity to talk on this very important disease. I have not made detailed slides of location of my country or myself, but just one thing is enough, that we have in the north, we have got a great neighbor, a great country, great friend, that is China. I think this introduction is sufficient for about our country, that it is a neighbor of China. And secondly, I just want to narrate one story that uh, when the COVID started in China, in Wuhan, we had about 5,000 students, Pakistani students studying there. And their parents, they tried their best to call those children back to home. By Chinese authorities, they were very wise and very kind to us. They did not allow them to go back to their countries. Instead, they homed them, and they fed them, and they made sure that they didn't have a virus. And this thing saved us from a big crisis. So while the other countries, they sent their aircrafts and planes to evacuate their own citizens, and then those citizens then spread the disease in their countries. In Pakistan, COVID did bad things, but it, on the peaks, in the three peaks, the incidence never went more than 6,500, and we are on the below lower side of the third wave, just less than 1,000 cases in the whole country. And we hope that just in 30 days we will be reporting zero case. The topic I've shared is close to my heart, because about the biomarkers for monitoring of patients of COVID-19, the good, the bad, and the ugly. This is the disclaimer. We will have some proprietary names, but just for giving information. Use of biomarkers in COVID-19. A battery of biomarkers are tested in almost all the patients of COVID-19, regardless of clinical indications. As Dennis told in the intro, that the disease, nobody knew exactly what this disease is in the beginning, and we didn't have any clue about it. So a lot of tests were done in the hope that they will be doing better in the patients. So in almost all the patients, CRP, interleukin 6, procalcitonin, ferritin, LD, and D dimers, it was done. And now, but I think it is a time that we should do an audit, that whether these biomarkers, all of them should be used, or only few of them are useful, or some may be used in specific conditions. So today we will carry out an audit of various biomarkers, but first we will discuss some knowledge-based facts, and then we will see which markers were very useful during the pandemic and which caused just wastage of money and manpower. So right from the beginning, I will discuss some myths about COVID-19 lab tests. And this is, since I'm a teacher, I am in the bad habit of asking questions. In this format, we cannot ask questions directly from the students. But if you have got a pen and a paper with you, Please do some critical thinking and write the best answer you have got on your paper, and then you can compare the best answer with your answer. Question number one is, a medical researcher is validating, determining diagnostic accuracy of various biochemical markers used in patient of COVID-19. Which of the following tests she should use as reference standard, gold standard? These are the 5 tests, and what do you think should be used as the gold standard? Please write on your paper. This will keep you awakened, and you will be with me throughout the presentation. Yes, gene sequencing is the gold standard. This is a very important thing. So first, myth number one is that RT-PCR is a gold standard for COVID-19. RT-PCR is not a gold standard for COVID-19. In reality, RT-PCR has only 50 to 70% sensitivity, depending upon the specimen site. Truly speaking, only gene sequencing by NGS can be regarded as gold. Joseph also mentioned about gene sequencing, but and told that it was used in Germany also. But there are problems with gene sequencing because it is extensive, it is expensive, and it is involves a lot of expertise. So everybody cannot do it. So RT-PCR became the most commonly used gold standard in research studies. Although in China, there was a paper from Shanghai that they did NGS gene sequencing in all the patients who were RT-PCR negative. So if RT-PCR negative, they didn't declare them disease free. They did gene sequencing, and by doing gene sequencing, they overcome the this pandemic very quickly in Shanghai. Second question is, a 47-year-old man is suffering from fever and sore throat. He has a history of contact with a patient of COVID-19. His lab investigation result showed HCPCR is normal, HSP-CRP is normal, IL-6 is normal, procalcitonin is normal, ferritin is normal, and COVID antibodies, they are negative, antigen is also negative, and they didn't do PCR. What should be the next action in this patient? Antibodies should be repeated. Acute phase reactants should be monitored on daily basis. DNAML should be carried out. No test is required. COVID-19 is ruled out. RT-PCR should be done. So please write your what do you think is the best answer on your paper, and then wait for the best answer. Yes, RT-PCR should be done. So second myth is that biomarkers can be used for the diagnosis of COVID-19. Some people, if they get symptoms, they go and get those in Pakistan, especially. I'm not saying in other countries. In Pakistan, they would go to a private lab and get their those 5-6 tests done instead of getting PCR. And if they are negative, they say we are not having COVID. In reality, biomarkers should only be used for the monitoring of an already diagnosed patient of COVID-19. Currently, most suitable and reliable test is RT-PCR. There is no doubt about that. HRCT, which is a radiological investigation, is also very useful, but it is not in the purview of today's talk because it is a separate topic from the radiology department. Question number 3 is, a 39-year-old woman is suffering from fever and joint pains. Her lab investigation revealed CRP is raised, IL-6 is raised, procalcitonin is normal, ferritin is raised, antibodies are normal and negative, antigens is negative, and RT-PCR is negative. What should be the next action in this patient? Should we start with tocilizumab, Actemra, or antibodies should be repeated? Dexamethasone should be started immediately. Other viral diseases should be ruled out. RT-PCR should be repeated weekly for 2 weeks. What do you think is the best answer? In 5 seconds, just write your answer. 1, 2, 3, 4, 5. So the best answer is yes. Some of you might have been written the best answer. Other viral diseases should be ruled out. Myth number 3 is biomarkers are specific for COVID-19. Yes, this is a very common think that if biomarkers are raised, it is COVID-19, whereas reality is it is not. But these biomarkers are not at all specific for COVID-19. They are raised in many infections, inflammation, and malignancies. You may have a viral infection, you may have a thyroiditis, and all these markers may be raised. Myth number 4 is that HSCRP is the first biomarker to rise in infections in COVID-19. HSCRP is a very good marker, but does it rise first? No. First marker to rise is IL-6 hours before the HSCRP. This is very important. Why? We will see in the subsequent slides. So interleukin is a cytokine that causes induction of various acute phase reaction. So it is the mother cytokine which causes release of other biomarkers such as CRP and procalcitonin. So IL-6 increases much earlier than CRP. IL-6 is a multifunctional cytokine that transmits cell signals and regulates immune cells. It's a multifunctional cytokine. IL-6 is of major immune importance because of its pleiotropic effect. Pleiotropic means multiple effects. It is a wonderful cytokine. Circulating IL-6 levels are closely linked to the severity of COVID-19 infection. Due to its rapid replication, SARS-CoV-2 virus shows an elevated response of IL-6 induced severe respiratory distress. Serial monitoring is also important. First, on the initial evaluation, IL-6 should be done and then it should be monitored serially. Potential benefits to assess worsening, clinical features, and disease progression in COVID-19. And one very important indication of IL-6 is that it can be very helpful in early diagnosis of impending cytokine storm syndrome, CSS. Cytokine storm syndrome is a very dangerous and almost lethal phenomena which occurs in COVID-19. And IL-6 is a marker that can be used because it is very, very high, maybe 1,000-fold above the normal. Several large studies have reported markedly raised IL-6, but some authors have denied even the existence of CSS in COVID-19, and some have also denied any role of IL-6. In science, all type of opinion that goes on, and one cannot stick to one opinion. CRP CRP is a well-known marker, time-honored marker of infection, any infection, viral, or it's a non-specific acute phase reactant. Sensitive biomarker for inflammation, infection, and tissue damage. It starts rising 4 to 6 hours and peaks by 36 to 50 hours. Elevated CRP, a marker of bacterial or viral, both. It is not specific for viral. In COVID-19 patients, CRP more than 42 milligram per liter are more likely to develop. For my younger colleagues, please concentrate on the units of CRP which is used. This is a very, very important point. This is also a point for patient safety because two types of units are used, milligram per liter and milligram per deciliter. If you are using milligram per liter, then the lower cutoff is 5. But if you are using milligram per deciliter, it is 0.5. So never ignore the units which the lab is using. Procalcitonin is a glycoprotein without hormonal activity. It's very interesting that it is a precursor of a hormone which is secreted from the thyroid gland. Procalcitonin gene, but its gene has been found in other tissues like liver, kidney, adipocyte, pancreas, and other tissues. Procalcitonin is also activated by IL-6, so its mother cytokine is IL-6. PCT is activated by gamma interferon. It is not activated by gamma. This, I think students should remember this, that it is not activated by gamma interferon, and that's why it's not a viral marker. It is not a viral marker. It's a marker of bacterial disease because gamma interferon is a cytokine for viral infections. PCT levels are increased in bacterial infections, therefore can be used to distinguish between bacterial and viral infection. The higher the PCT levels in COVID-19, patients may indicate concomitant bacterial infection. Ferritin. Ferritin is a wonderful friend. All the clinical chemists, chemical pathologists, they are very friendly with ferritin. It's a very good marker of iron deficiency, nearly 100% specificity. But its role as APR is marred by the fact that its rise may not be prominent if there is a concomitant. Now, in countries like Pakistan, third world countries, their iron deficiency is rampant. So one should be very careful if you are when you are monitoring the patient on the basis of ferritin. In COVID-19, mostly increase in patient with COVID-19, useful biomarker for the intensity of inflammation in patient with COVID-19 can be considered to have a good ability to predict poor outcomes. So this has been reported in January 2021. This cartoon depicts the relationship between IL-6, CRP, and PCT. IL-6, as I said, it is the mother biomarker, and which cytokine, and it causes release of CRP and PCT. So that's why IL-6 is raised prior to the CRP and PCT. Then another biomarker, D-dimer, it was introduced in 1990 as a fibrin degradation product. Small protein fragments in blood post-fibrinolysis, contains 2D fragments, and it is useful in range of thrombotic pathologies. You can see in DVT, in pulmonary embolism, it is raised. Recently, it has been reported to be elevated in patients with COVID-19, and some reports have shown that even without pulmonary edema or DVT, which means deep vein thrombosis, the D-dimer is raised. Now, I will show you whether this fact is true or not. Lactate dehydrogenase, by the way, its a new abbreviation is LD, not LDH. So LD is an enzyme that produces energy. LD enzyme catalyzes the conversion of lactate to pyruvic acid. And its clinical significance, you all know that is a marker of anemia, megaloblastic anemia in cancers, germ cell tumors, ovarian cancers, lymphoma, leukemia, and neuroblastoma. So wide range of diseases in which LD is raised. In COVID-19, there were reports that there is if it is raised, there is six-fold increase odds of severe COVID-19, and another report showed more than 16-fold increase in odds of mortality. But these are just few reports which showed the role of COVID-19 in LD in COVID-19. Now, a little bit of methodology, because I'm a lab man, so I think it is quite appropriate that we should have a passing remarks on the methods. As estimation of these biomarkers in larger labs is done on the chemiluminescence assays. One should select one platform for many of them, like Maglumi from China, Alexis, Cobas, Architect, Abbott, and others. Many ELISA systems are also available, but the specificity and sensitivity of ELISA is much lower than chemiluminescence. In a presentation in a webinar on 13 July, I will discuss compare different methods of antibody testing for COVID-19. If you are working in a small lab, or you require an urgent test in emergency situation, then there is another instrument by the name of Fine Care from Wondfo. It is not a ICT. I tell you, it is not ICT. It is amino fluorescence. Some even the technical people didn't know it. They said it is a rapid method test. Yes, it is rapid, but it is not lateral flow. It is not ICT. It is a immunofluorescence system. Immunofluorescence is a good technique, and the advantage is that it gives you good result with optimum accuracy. So we can do many biomarkers on this system. Just a passing remarks about the ABGs, blood gases. Blood gases are very important test in COVID-19 patients. We can have a separate full talk on ABGs, role of blood gases in various diseases. And this is a wonderful system of Wondfo, which I have been using for last 2 years. It is cartridge based and quite useful for labs with low turnover. Biomarkers in COVID-19 epidemic local experience. We analyze estimation of biomarkers in about 265 patients of COVID-19. Patients included both indoor and OPD patients. Repeat analysis, by the way, OPD means outpatient departments who are not admitted. Repeat analysis of these markers range from 1 to 9. So in some patients, just one test, in 2, 3, or maybe up to 9. Outcome measures is percentage of positive rates, that is frequency of high levels of biomarkers as compared to the cutoff value. So we analyzed our lab data and we found that IL-6 had the highest positivity rate, 62%. Now, please remember this fact that if one patient is admitted and his or her initial IL-6 is raised, subsequently his or her all IL-6 will be raised gradually coming down. So that's why it has shown the best sensitivity or best positivity rate, followed by ferritin and then CRP. PCT was not raised in much of the patients. LD was only in 14% and D-dimer only in 8%. So we can infer that many biochemical parameters were significantly different between the severe and mild groups. Only CRP, IL-6, and ferritin levels were found to be pathologically elevated. So we can classify that these are good markers. And similar finding was reported from China in New England Journal of Medicine last year. They also found that these three markers, they were quite good for COVID-19. Then some markers were had specific indications. If you suspect a bacterial infection, then you should go for procalcitonin. I will not advise, I will not recommend procalcitonin in all the patients, rather only in those patients whom you suspect a concomitant bacterial infection. D-dimers should also be done only for those patients with have some hematological disturbances, which can be evident from blood CBC, coagulation profile, etc. Only then D-dimers should be advised, not across the board for all the patients. LD, I found no advantage. LD testing is not useful, it is useless. LD estimation provides no additional information and has almost no role in COVID-19, should not be used. So it is an ugly biomarker. So my take-home message is biomarkers should be used according to the situation of the patient, not in all patients. Use of all the biomarkers across the board in COVID-19 patient merely results in wastage of precious resources. Rational use of biomarkers will effectively reduce the cost of the patient care. And in the part of the world from where I'm speaking, the economy is always very important, and we want to cut the expenses which we can do, and instead diverting our funds to. So I always advise my colleagues, laboratory colleagues, to please divert their funds to the better markers rather than doing the just traditional all the markers. Thank you very much.
Thank you, Professor Aamir. Thank you very much both for your knowledge and your story. And now I'm pretty sure that we all have gained a better understanding of which biomarkers that were recommended to use in the clinical management of COVID-19. So, and then we shall proceed to Q&A session. And here I got several questions which I collected during this presentation for two experts. So the first question is for Dr. Josef. So we saw the strategy you showed at September last year in Germany. The antigen test is used before the PCR, and positive antigen patients should be sent for later PCR confirmation, right? And some of our audience asks, what about the negative antigen test? And which means what to do with the negative patients?
So usually the assumption is the negative patient is negative. Of course, we all know due to a low viral load, sometimes the rapid test will not show a positive result, although the person can already infect other people. So what now happens is that most of the time people are required to take one PCR test per week if they are in certain professions independently of the case, if their rapid test is negative or not. So a positive rapid test will always be followed through immediately. The negative tests, which have to happen, for example, for people in elderly care every second day, they will also do a once a week PCR test just to be on the safe side. But usually then the rapid test will be trusted, of course. And if there are symptoms and the rapid test is negative, there's still a PCR will be performed.
Okay, thank you for your answer. And our next question is still for you, Dr. Joseph. We know your lab did the validation study of our antigen test, and I think it is the nasal swab. And we really appreciate your effort, and I do hope that it could meet your standard for real-world application. So our question is, what could be the main consideration when choosing antigen tests for COVID-19 testing? And what should we do before applying to real situation?
So I'm not sure if I understand the question now correctly. So you mean?
Yeah, I can further explain by the main consideration of choosing antigen test, because we know that there are a lot of from antigen tests that from different manufacturers. So we wonder what aspects would you pay attention to, like specificity, sensitivity? I know these two indicators, they must be the higher the better, but what about other aspects like?
So in terms of other aspects, of course, in terms of the general reliability that the test produces a result quickly, and of course from different manufacturers, still the tests are very comparable. So it will be about what features you can use as an add-on to make it more useful for the people. So it can be a quicker result, also a way of having the result available in a digital way rather quickly, so that it can be used as a proof that you are negative or allowed to access certain areas where you cannot go without having a recent test result. So if there would be a way to bring the result more or less immediately in a smart way onto the smartphone or so, then this would be a big plus compared to other tests. The applicability, if you do the swab in the nose or the mouth or there are different methods. They are all now quite established and everyone prefers something different. So it will not really be possible to have something that is the perfect fit for everyone, because everyone prefers other methods of taking the probe. But generally the population for each of this type is very big anyway. So generally the added features, what comes in terms of convenience with the test being performed, would really be key.
Okay.
So, and also because at the moment all these tests, the officially performed tests are being paid for by the government. So pricing is not necessarily the biggest issue, but rather what you get with the whole package. And also maybe the ease of performing the test rather quickly for many people would be a good help.
Okay, thank you for your answer. And next question is for Professor Aamir. From your speech, you have introduced in detail about the interleukin 6, and it is indeed a marker that has been widely applied for COVID-19 patients. And now there are two questions related to interleukin 6. The first one is about the application of interleukin 6. Can we depend interleukin 6 alone for predicting the disease progress?
Thank you very much for this question. Very important question. No, you cannot depend alone on it. As I told you, at least 3 biomarkers should be used: IL-6, HSCRP, and ferritin. The distinguishing feature of IL-6 is that it is an early marker for respiratory distress, and secondly, if it is very, very high, it shows you impending cytokine storm syndrome. And if you are, it has gone up to the more than 80 or 100 picogram per ml, then one should consider using a biological agent like Actimera, tocilizumab. And so that was, although some people have recommended not to use Actimera now, but some people, but others are still using Actimera. So one indication of IL-6 is using in for monitoring of patients who have got CSS. But one another important advice to my junior clinical colleagues, that if you are monitoring a patient of clinical this Storm syndrome, then IL-6 monitoring should not be done, because this Actimera is not anti-IL-6, it is anti-IL-6 receptors. So it will block the receptors, it will not reduce the production of IL-6. But the indication is that when you should start it. But when you have to stop it, IL-6 is not the best test for that. Thank you.
Okay, thank you. So the next question is also related to interleukin-6. And this audience asked, should we test interleukin-6 for suspected or antigen-confirmed cases at primary care setting?
No, I will not. No. I will not recommend that for primary care setting. If only antigen is positive, IL-6 is indicated only in those patients who are clearly RT positive, PCR positive, and have got the symptoms and HRCT score of having the pneumonia, or which means the ground glass opacities, GTOs. Only in those cases, IL-6 should be advised. Usually these patients are admitted in hospitals. Thank you.
Thank you very much. And the next question is for both Professor Aamir and Dr. Scheiber. Yes, and since the vaccination is going actively all over the world, and could you please share the current vaccination strategy in your country, and how will the popularity of vaccines affect the later testing strategies? Maybe Dr. Joseph, you start first.
Okay, so thank you very much. So initially here we had prioritization strategy, 4 different tiers where people were sorted into depending on their personal risk, to have a triaging that the people being most at risk, so people being older than 80 and so on, and workers working with them, got the first doses. And then basically this has been worked through the different priority groups. The start was not very efficient here in Germany, so it was a rather slow start. And there were some problems with the AstraZeneca vaccine and being not that popular despite having also good results. So at the moment in Germany, 4 vaccines are being used. This is Pfizer BioNTech being a German company, which is the major part of the vaccination campaign. And then you have AstraZeneca Oxford vaccine, then Moderna and Johnson & Johnson, and also the state here now acquired some doses from Sputnik, from the Russian vaccine. And so since yesterday, the vaccination is accessible for everyone basically on short notice. So after the priority groups, everyone who wanted to get the vaccine got one, and now everyone can sign up and usually gets an appointment within 2 or 3 days now, which will help us from the, when this structured campaign was run through until 2 days ago, we are now at a vaccination rate of around 53-54%. And now we will likely, that the objective is to be at around 70% by end of the month. And then of course the problem comes with some people not wanting to be vaccinated and so on, but it seems to be a percentage of less than 15%. So we will likely be able to get to a ratio of around 85% vaccination around late August. So we are in absolute numbers vaccinating, for example, more people per day than the US, despite having only a fifth of the population. So this is going very effective now. And this will affect the testing strategy. So because, as you know, with this new Delta variant, it's not that new anymore, but now the first case is being reported also here in Germany. It will still be tested quite heavily because even vaccinated people can transmit, although the cases are usually relatively mild. Some exceptions are always there, of course. So I assume the test, the government announced yesterday that the number of weekly tests in schools will be even increased because the younger people have a lower vaccination rate. So I see the next quarter, rather, there will be more tests for less cases to be able to then really track down the now a really small number of cases in the country, to be able to hopefully be able at some point to really more or less get completely rid of the virus, which will be driven by tests and vaccination. So there's of course also the discussion having a third shot of the vaccine if this is necessary as a booster. So the vaccines for that have been acquired already. And apparently this will also affect, so this really depends on how the different virus strains and so on will develop in the future, but the testing will remain for a while at more or less the level. And if we can get to the point that the self-tests are more linked to a certificate, this will be even further increased, because still for the different centers, they are completely reimbursed by the state, which is of course decreases the burden to get the test, because everyone can go there, just show up and get the test immediately. And this will rather go up for people being cautious. But hopefully at some point we will be at everywhere in the country at COVID-0, so that is no longer necessary.
Okay, thank you for your sharing. And Professor Aamir, you can share your opinions.
In Pakistan, once again, we were very lucky to have a great neighbor, China, and they immediately supplied us as a donation, I think more than 1 million doses of Sinopharm. So we started with the Sinopharm. I myself has been vaccinated 2 doses of Sinopharm, which has been approved by WHO also. Then we have got another Chinese vaccine, which is Sinovac. My wife is vaccinated with Sinovac, and we have also started producing our own vaccine by the name of SparkVac, of course with the collaboration of China. And these are the 3 Chinese vaccines which are very commonly used in our country. But AstraZeneca, we are also using it, especially for those people who want to travel abroad, and Pfizer also for travelers. About the testing, I think the best way to test the effectiveness of vaccine is testing the spike proteins. But I will not recommend testing for spike proteins in all the patients because it is not necessary. Thank you.
Oh, thank you very much. I actually have a question. It's about neutralizing antibody. So if coronavirus is going to coexist with us for a quite long time, and do you think the neutralizing antibody test is going to be an inevitable trend? Like the majority of people will have to test this. What's your opinion on this?
This is a very good question, and many people ask about the neutralizing antibody. First, let me make it clear what is actually neutralizing antibody. Actually, neutralizing antibodies are very methodological tests, very difficult tests, which are done in the lab and on the virus grown on cells, and they see that whether this antibody neutralize the viruses or not. So, and it cannot be used in clinical settings. So first be clear that actually neutralizing antibodies are those which are done on virus culture. So what are the neutralizing antibodies which we got here in which is called NAB. They are these the markers. They are the markers which has been standardized against the neutralizing antibodies. They are not actually neutralizing, but they have been standardized against the neutralizing antibody. Yes, I agree with you. They are very good tests, and especially for the those patients who want to see their effectiveness of vaccine. Thank you.
Thank you very much for your answer. So we got another question for Dr. Joseph. Is do you think with the positive new case daily below 1,000 in Germany, do you think PCR test will prevail antigen to be more widely as COVID positivity rate is low now? I understand these questions because I don't quite understand it.
I'm not exactly sure. I'm just reading it.
So you want me to repeat it?
No, I'm just reading it here myself. That's fine. I saw it.
Okay.
There will still be, because the official requirement for the health authorities is a person is post-COVID positive with a positive PCR test. The rapid test is an indication for that, but not yet the official diagnosis. When you have a PCR test, also the whole thing with the contact tracement, quarantine and so on is being triggered, which is not being triggered by a plain rapid test result. So both of them have their use cases in the future, and I believe it will be stronger on the rapid test side just to find the occasional case that is still there and will inevitably come up again, because you can easily travel everywhere now. But still the PCR, so both of them will be used in the future. And I think rather the number of rapid tests will be higher and the PCRs will be more focused for certain occasions, but there are still some countries that require 48-hour-old PCR test or so to be able to enter. So this will also continue for a while. So it will be interesting how this will be in about a month, but at the moment we will rather probably be at a very similar level.
So that's the end of the answer.
Yeah.
Oh, thank you so much. I hope this audience has got the answer he wants. So due to our time limit, we'll only have one more question for Professor Aamir. The usage of D-dimer seems to increase rapidly in his country, this audience that. So when should we test the D-dimer for COVID-19 patients?
Good question. I think D-dimer should not be used in all the COVID patients, whether they are admitted or not. If there are some hematological indications such as abnormalities in the complete blood count, or there are coagulation profile abnormalities, only then D-dimers should be used, because it is a marker of DIC or hematological disorders. It is not a direct marker of COVID, because it is well known that COVID-19 has got hematological effects. So, but not in all patients, not at all. So using D-dimer in all the patients, I will not recommend. Thank you.
Okay, thank you for your answer. So due to the time limit, our Q&A session has to end here, sadly. Okay. So Dr. Joseph and Professor Aamir did provided us with a lot of information and inspiring thoughts. And Wondfo Biotech kept working on to present the most satisfying and complete COVID-19 solution since the beginning of the COVID-19, and no matter for testing or clinical management. So as you can see from this slide, Wondfo's product list covers from diagnosis to clinical management and to post-vaccination screening. For diagnosis, we have real-time PCR, antigen, and antibody tests. Our real-time PCR assay targets on both regular coronavirus and identified variants. Room temperature storage and ready-to-use reagents can greatly improve the testing capacity. And for antigen tests, to meet requirements of different application scenario, we also provide test kits that use different sample types, including nasopharyngeal, oropharyngeal, nasal, saliva, sputum. And we also provide influenza and COVID-19 antigen combo tests to help the initial differential diagnosis, accurately guide the further clinical decision. For antibody tests, we have test kits that can detect total antibody test, and IgM, IgG that based on colloidal gold platform and fine-care fluorescence immunoassay platform respectively. When it comes to clinical management, Wondfo provides solutions on 3 platforms, namely fine-care fluorescence. The second one is dry chemistry platform and electrochemistry. For the biomarker, Professor Aamir just mentioned, like interleukin 6, ferritin, CRP, PCT, and D-dimer are available on fine-care platform. And LDH can be achieved on dry chemistry platform. A blood gas analyzer and optical coagulation analyzer are from our electrochemistry platform. And blood gas analyzer can make a comprehensive assessment of the patient's physical condition by measuring the most complete indicators. And coagulation analyzer can help to evaluate coagulation that may be experienced by COVID-19 patients. For post-vaccination screening, we provide RBD antibody and neutralizing antibody based on colloidal gold, fine-care fluorescence, and chemiluminescence platform respectively, which we hope could assist a vaccination program. If I'm going to use one sentence to conclude this, epidemic evolves, our Wondfo also evolves, and always try to be better. And here we almost comes to the end of the webinar. Again, thank Dr. Joseph and Professor Aamir for sharing their insights with us, and thank all the attendees for joining Wondfo Biotech. We hope you have learned and enjoyed this webinar. Also, thank Wondfo Biotech for presenting this webinar and giving us this opportunity to have conversations with experts in this field. And Wondfo Biotech will host another webinar focusing hotspot issues during post-vaccination era in mid-July. And we are looking forward to everyone's participation. Also, you can follow the Wondfo's official account on LinkedIn, Twitter, and Facebook to acquire latest information of Wondfo. And lastly, we will have an e-certificate sent to each of our attendees for showing our gratitude for your time and participation. For any question you raised during webinar, if your questions are still remain unanswered, we will collect and deliver them to our expert. Yes, and you can send all your questions to through this email. And yes, we will convey all your questions to our 2 experts and get back to you as soon as possible. So see you next time. Maybe in mid-July. This is the end of the webinar. Thank you all for participation. Thank you, Professor Aamir and Dr. Joseph.
Thank you.
Bye.
Bye.
Everybody's free to leave the Zoom room. Bye.
Thank you, Janice. Thank you, Amber. Thank you, Joseph.
Thank you.
Very interesting sharing. Thank you.